Hey everyone, welcome back. Good to see. Good to see you. You're still here. And after such an informative discussion with Dr. Badelia, we now have Dr. Fauzia Khan joining us. So Fauzia Khan is a healthcare leader, a senior executive, and a serial entrepreneur. Her experiences extend from running a healthcare IT portfolio of $5.3 billion. She has built two successful startups before becoming the co-founder, chief medical officer, and chief operating officer of Persivia. She was the co-founder of Alere Analytics, which had a successful exit in 2012. And she also is the co-founder of Diagnosis One. She's a textbook author. She is the author of a textbook on diagnostic testing. She previously also was a physician at UMass Memorial Center, UMass Medical Center. She's been recognized as Entrepreneur of the Year for Asian American Women in Business 2012, Outstanding 50 Asian Americans in Business. And she's also been awarded for High Tech Business from the Immigration Learning Center in 2014. She's published in US News and World Report. And I'm really excited to hear from her talk about the role of artificial intelligence in COVID detection. So without further ado, I will hand the mic to Dr. Fauzia Khan.
Thank you, Maureen, for a wonderful introduction. Let me share my screen. I have a small talk on role of AI in COVID-19 and how my career has spanned over the last 15 years, looking at AI and a role it plays in healthcare. We will quickly review the COVID-19 statistics. Then we'll look at the principles of infection control and what role AI can play in controlling these infections and preventing these infections. How can we help our providers, giving them the right information at the point of care, and look at some of the models which played a great role. They were everywhere. So when you open the TV, Dr. Deborah Brex was talking about these models, and we'll look at some of these models and see what they were predicting and what were they based on and what we can learn and how we can innovate in the future. I know there are a lot of entrepreneurs here also. Just reviewing some of the death counts, we have about 114 million cases globally of COVID-19 and more than 2.5 million deaths. In US alone, we have more than 28 million cases, and our death count goes on and has reached more than 500,000 in the United States. We talked about Brazil and how they did not put any control measures. So it's no surprise that they have a very high death rate as well as the disease burden. In India, everybody's speculating why India has so much higher disease burden of 11 million cases, and their death count is on 157,000 and going higher compared to Pakistan, where it's about 500,000 cases and the death count is around 13,000. There are a lot of hypotheses, many of them are not supported, but I will touch upon them, although we don't have the scientific evidence to support any of that, just to see what people are saying. And in this pandemic, as Nahid was also talking about, there's a lot of myth and there's a lot of misinformation out there, and we had to deal with all that. We did have opportunity to work with the CDC and the public health authorities, and we saw some of that misinformation reaching to them, and then it did have some impact, even the work of these agencies. This is just giving a view in a picture format of how many cases that they are there. We know that California, Texas, Florida, Massachusetts itself had a very high disease burden and a death rate. Now, this is very interesting because it shows that the COVID-19 did strike a particular age group, which is the 65 years and older, and there's a higher death rate, as well as lab confirmed COVID-19 cases are much higher, and the hospitalization and the clinical course of 65 years and older is much more serious than in the younger folks. And this is one of the reasons that, or hypotheses, which we really don't know, which has been proposed that in Pakistan, we didn't see such a higher disease burden or death rate because we have a younger population. And so does India. But then we had other hypotheses proposed that maybe it is the practice of BCG vaccination, which is protecting the Pakistani population, and maybe the density per population, which is much higher in India, that has a role to play. And then we also heard that India's policy, very strict policy of lockdown, led to lockdown and scatter, where the villagers were taking some of the disease back to the villages. And since Pakistan didn't do any of that, we didn't see such a high incidence. We really don't have any scientific evidence behind these. I just am talking about these, that these are proposed, and many of them even discussed in medical journals, but we don't have any control studies so far to prove that. We have been in Persevere, and my career as a pathologist has been very deeply involved with laboratory testing. I don't know if all of you are aware, but there are federal and state regulations to report certain infectious diseases to the public health labs, and the public health labs then report to the CDC. Normally, the annual burden of these lab testing is around 20 million, 30 million cases are reported. Here we see such an increase. We see 330 million tests just done on COVID, and our positivity rate is from 8 to 9% in the lab testing, although people think that our positivity rate in the general public for COVID is much higher. This is the disease journey, and it starts with a pathogen which is transmitted by aerosol. In this case, it's an RNA virus. Patients seek primary care, whether it's hospitals or providers. We collect the data. The data is collected from the hospitals, from the labs, and then this data is crunched by the data scientists. Some of them are part of our business as well. And then we did some modeling, AI, as well as decision support, and that helps curb down the infection. So this is an overall look, and it is very, very important. Is AI models is not just about the mathematical models, but what data goes into the models, and what hypotheses we are making, that also plays a big role in these models. These models are widely available, so we'll talk about them. You can download the code and you can run them yourself. But the information which goes into the models is also very, very critical. We have been involved with electronic lab reporting, as Vinny was mentioning. D1 started with deploying the statewide electronic lab reporting system in Massachusetts Department of Public Health in 2006. In Iowa, we were doing statewide reporting for all notifiable conditions, and COVID-19 certainly is one of them. Since 2012, when COVID struck, CDC recommended Texas to use Persevere for their electronic lab reporting in 2020. They were in a state of they were having a big challenge with dealing with their providers and reporting them, and we did help them on board these providers. We worked with the CDC. They asked us certain advice about why is the data so poor coming to the state lab while the data does exist in the EMR. Why is there so much discrepancy in this data? And we did analysis and studies on our data, and we found out that the data which lives in the EMR is actually not finding its way into the state labs, and providers don't have a way to send this data electronically, although we spent about $32 billion in meaningful use, but there is no meaningful use or exchange of data between the beautiful Epic systems which are deployed in the hospitals and the lab requests which are going into the state labs. We have had these systems running quietly, first by D1, then within LA Analytics, and now within Persevia since 2006. And they were not a big part or center of the work Persevia was doing at the moment. Um, but they were running quietly, as I said, and then we saw suddenly an 80x increase in the testing volume, and our systems had to be tweaked, and we had to get involved with these systems and pay them attention because they were not built for such a large volume of testing, which was being done and transmitted statewide. For instance, the daily counts of tests, and these are all the notifiable conditions, not just COVID. They went from maybe 1,000 tests to 80,000 tests per day. We never thought we'll see such an increase in testing. Um, CDC does talk about one of our systems which has been deployed in Iowa, and this system has helped Iowa in handling certain outbreaks, such as there's a large outbreak in 2012 where this helped them gather the data, and lab reporting is very critical and central to public health, and it gives the states and the nation information of where the disease is happening, where the outbreak is most, how to channel their resources, and how to handle these outbreaks. So the testing volumes and the testing data is central to a public health response. There were different models which were proposed at that time, which were predicting the death rate. It went from a very high death rate from Imperial. The Imperial model was very aggressive by Dr. Neil Ferguson, who was predicting about 2 million deaths by August. And that is from the Imperial College of London University. And this was a very, very high count of and very aggressive projections. The model was the same. The three models that we will talk about, the Yu Yang Ju model, the Imperial model, and the IHME model. This is the model which Dr. Birx was talking about on the TV, and you must have seen the projections. I have a picture of that, which was projecting much lower cases, and they were saying about 60,000, and we will see that information as well. But the model which was the most close at that time for in April was the Yu Zhang model of prediction. This is just the daily tracker. I just wanted to see and share with you the 7-day average death rate. This is the model which Dr. Birx was showing time and again, which is the IHME model, and that predicted about 60,000 deaths. Actually, we had about 160,000 deaths. So this model was off, but this was the most commonly cited model by the White House, and a lot of the responses were based on this. The Imperial model, as I talked about by Dr. Neil Ferguson, projected about 2 million COVID deaths by summer. But we didn't see anything close to that. And actually, Dr. Ferguson resigned from his position, citing error of judgment. Why the IHME model didn't predict as well? All of them were using the same mathematical model. Um, but one of the policies this IHME model had was to base the projections on Farr's law, which is the normal or the Gaussian distribution, and not predicting the second wave and not realizing how high this death rate will go. The most reliable model actually came from an MIT graduate, Yu Yang Ju model. This was a 26-year-old graduate of MIT who started predicting these deaths, and he was very, very close. So his prediction of 80,000 deaths by May 9 was very close to the actual death toll. And also later on, the model also predicted well, but eventually the model also did not, it kind of wither away. It didn't predict anymore, but for a long stretch of summer and early spring, it was the most accurate model. So what was going on? What was different about this model is that although they're using the same mathematical model, the inputs were very different. The IHME model and the Imperial College of London model were using all the different data inputs such as um, hospitalization data, testing data, the COVID testing positivity rate, but many of these were unreliable. And we knew that also. We were looking at the test information which was coming in. Many of the tests which are reported were on paper. They still are on paper in the United States of America. Three of these labs do have our electronic lab system. Many labs don't have an electronic system of reporting, which means that the providers are still faxing the lab results or sending CSV files. So you can see that how inaccurate the data can be. There are data entry issues, there are mistakes being done, there are delays in uploading these tests into electronic systems, which the CTC does supply to all states. So that data was unreliable. We also now know that the test data originally or initially was also unreliable. For instance, the ID Now, the LA device, which is now Abbott, and we worked with that device in LA days, was not as accurate as we would like to be, at least initially. And some of the other tests which CDC was sending out were also inaccurate, and they were not really have a very high predictive value. We were requested by our hospitals and our providers to help them with quickly triage the patients so that the hospitals can direct the care resources and allocate these resources efficiently to the right patient. So we did bring out a model using the structured and unstructured data. We used some of our NLP or natural language processing to pick up data such as travel data or social encounter data, as well as some structured data. And we did model and recommend a course of action. We looked at the ED presentation, and we took inputs of fever, shortness of breath, cough. As I said, the NLP was looking at travel history and exposure to COVID. Some of these things were present in the notes, but were not present in the structured data. We looked at comorbidities, we looked at the patient's age, and we had a good model. It's still being used actually, although the testing is widely available now. But um, physicians are still using that to allocate their resources and to reach out to these patients based on this model. It was the model that we used was a Bayesian model, which did the posterior probabilities, and it was pretty good and it worked well for us. It continues to provide this information to providers at the point of care so they can channel the resources for these patients. I just go over my journey. I got interested in AI, and we started with PGMs or probabilistic graphical models, built an AI engine based on that, and it's the semantics Bayesian engine. And we deployed that in 2006, the same year we went live in Massachusetts. And what it does is really very efficiently maps the labs and their disparate data. The labs are not using standardized set of data. They are using some structured data, but many of their codes are not standardized. So we have a mapping engine to make it very simple, and that helps labs to map to a standardized vocabularies. And once we have the data, then we can send it to the CDC, then we can run all our models. But this data, as I was talking about other models, this data which goes into the models is very, very critical. Because we didn't have the right amount of or the accurate testing data, we saw that some of the models failed, like IHME model and the Imperial model, and the Yu Yang Ju model, which disregarded this data, knowing that this data is not accurate, and he went with only one indicator, which was the deaths, current death rate. He was able to project the future death rate based on that, although the mathematical model, SEIR model, remained the same for all of them, but the data was different and how the data was used was different. So this is a very key point I want to emphasize. if somebody wants to go into building these models, that the models are widely available now, the mathematical models, but what data we pick and how we project the data and what presumptions are made uh, for the data, that's also very, very critical. Actually, this is an interesting part to our story. When we deployed these systems in Massachusetts, we were also doing some syndromic surveillance based on AI for Massachusetts with Harvard School of Public Health. And the then Prime Minister heard about some of our work, invited us to come to Pakistan and deploy that. And we did do it. We got the funding from the CDC, and we deployed nationwide the system which we called ParkFin in 2007, and it survived two different governments. And after that, it fell out of use around around 2009, 2010. Um, we did offer again this time if our services are required to the Pakistani government. We didn't hear and we didn't push either this time. Um, we similarly launched electronic lab reporting for Iowa. I'm being touched on D1. D1 was supplying all the artificial intelligence around Alere devices. Alere was acquired by Abbott, and the Lay devices became the Abbott devices. And the one that you saw President Trump was holding one of the Abbott devices was actually the original Lay device. It's called ID now, and now they were doing the rapid PCR testing. Persevere was launched to provide AI um, support, clinical decision support, and AI in population health management. And we have deployed many of different models which help our providers take care of their patients. We have about 200 hospitals and about thousands of providers using that today. And similarly, we um, brought out the COVID-19 AI detection model, and it was also mentioned by Wall Street Journal. We were quite pleased with that, um, but it was a change of direction for us. Mostly we are focused on population health management, and there was a debate with our board whether we should be so prominent in COVID-19 detection and AI, but it was a decision we made to go forward with that. This is February, March timeframe where we didn't know that the whole year will be dominated by COVID-19 and we'll have no other story but this. But I'm just sharing with you how you feel, and at that time you don't know what the future entails. So it was interesting to say the least. Um, that's all I wanted to share. Thank you so much for listening to me on this Saturday morning.
Thank you so much for Dr. Khan. This has been such an informative conversation, very educational opportunity for all of us. I think one of my first questions is uh, kind of clarifying on one of the myths out there about the risks of using technology in healthcare. I think you touched a little bit about human error in healthcare and diagnostic testing. I wonder if you want to talk a little bit about any myths that you'd like to dispel.
Yes, there's a full spectrum of things. There are myths about using technology, and there are myths about not using technology. In our experience, I've been in healthcare IT for now 15 years. I came to the dark side, as they say. I left Beth Israel Deaconess Medical Hospital. So I think it's not possible to tackle today's pathogens without technology. So we really have to um, get friendly with this technology and get comfortable with these models, and there is no way back right now. I know there is a lot of literature about the negative impact of technology in medicine. This is an area of my interest, where how do you make, it's very easy to make an AI model today. You can download the SEIR model, a mathematical model, hire a young kid out of a good school of data science, which we do, and then let them play with that. That's great. You can do that. But how do you take that information now and make it useful for a clinician so that it impacts a patient's health in a positive manner? That's where it all lies. And that's an area of interest to me since I was a provider first and now I'm in healthcare IT. So the bad name comes because oftentimes we don't give enough thought to the design and the workflows. Those design and workflows for a provider and impact on a patient's health is equally important as that mathematical model that is giving us that information. So you're absolutely right. I can see both sides. I have physician friends who prefer to resign and say, we are not going to work within an EMR. We miss our traditional medicine. So there's a whole spectrum, Amreen, and I see that. But I think the answer is not to drop our IT, but to make it more friendly and within a provider's workflow so that it really helps them rather than distracts them from the patient care. It's a
Absolutely.
very interesting problem and something I deal with it on a daily basis.
Yeah, absolutely. So tell me about some of the challenges you're seeing with the adoption of artificial intelligence, whether it's policy challenges, human resources, you name it. You tell us about how we can scale.
Yeah, there's enormous amount of challenges right now, honestly. Look at the CDC. I worked in US and our journey working with the CDC and the public health authorities. And I think you asked Nahid also. Um, this was very difficult time for even within US to see how these institutions were struggling. Was it because of the politics? Probably that played a role, but we saw a shutdown in CDC. We were very engaged with them. They wanted our opinion. They wanted us to provide guidance. There was an RFI out from them asking about how to handle all this increased COVID-19 testing, how to, as you know, the state of testing in US is that it is on paper. So a large number of providers are faxing those tests to the state labs, believable though it can be. And that data, which is manual, then goes into these models. So obviously those models were off. But did the CDC respond to this challenge of forget about AI, forget about these models, but to make sure that they have um, digital information, they have the testing information which is correct and which is relevant, which is accurate, and which is complete. And they were so engaged in the beginning, and we were guiding them also because Persevia is unique that we have um, hospital clients and public health clients. So we have a background in both, and very few companies have that. But we saw a shutdown in the CDC, and now they're coming back after the government change. And we said to these guys, what happened? You guys disappeared. And they said, yes. And you saw some of that very public back and forth with the head of the CDC and the Trump administration. So there are so many challenges. So we need to have an environment, a political environment where the institutions can implement some of these very basic things. So AI is even far away just to get the electronic data, complete data. That's where we are struggling right now. And once we have that, even in the US, why we didn't go back to the Pakistani government, we would love to work and serve in Pakistan, is that they are struggling with so many challenges. So when the Prime Minister Shaukat Aziz invited us, we did go back and we did deploy the system. We helped them, we got the CDC funding. But right now the challenges are so immense that bringing in AI is the second step. First, we have to bring in some digital data, correct data, and then we can bring um, the AI. Even in US, leave aside Pakistan, in US we are very far from where we need to be, and this lack of accurate and complete data really hurt us in this pandemic because if you don't have the data, you cannot respond to it.
Right. So how can you build these models with more accuracy? Is there a way that you test them before you deploy them? Um, how do you know that some pieces of data are more critical than other pieces?
So when we look back, the Yu Zhang model, this 26-year-old MIT graduate, he realized something Professor Neil Ferguson didn't, that the testing data is incomplete, inaccurate, and should not be used in the model. So I think just keeping your eyes and ears open and see how accurate the data is and how the data is behaving and how the model is behaving, and then you need to keep tweaking that model. I think that's very, very critical. But in this case of Imperial imperial model, it was very public, and he ended up by resigning because they based the 2 million deaths by summer projections based on faulty, inaccurate data. I think you just have to have common sense and see where the data is coming from before you feed it into the model. As I said, the model is not the hardest thing. You know, when I started my career, I was so obsessed with these models. We are lucky to have Mansoor, who has a PhD in these mathematical models, and so we have his our CEO's help. But it now I know that it's all the stuff that goes into the model, the data which is going into these model, which is very, very critical and important and plays a very critical role. So we need to be very mindful. And you're right. Then the best thing is to keep testing and making sure that these models get better and better with time.
Absolutely. You've had so much experience from previously with Diagnosis One and analytics, but I don't know. COVID has been another animal of its own. What would you say surprised you most about the past year with COVID? What have you any learnings over the past year?
I mean, I was very surprised by how the US institutions failed in my mind. I really did not think that we will be in such a poor state even now that the test results, as I said, are still coming on paper. We don't have the data which is accurate, and these institutions didn't respond very quickly. And you know, we take all, just because we are from Pakistan, and you know, I have most of our development is done either by Pakistanis within Pakistan, or Pakistani Americans, or we have a group of data scientists in London. Um, so and we always think that in Pakistan we suffer from these lack of policy and lack of um, guidance from the institutions. But we saw that in US, and I'm sure you guys saw that in US, and we saw it from being engaged to them, and we saw them. Dr. Deborah Burks was aware of our work. We were part of some emails with them. We saw them engaged, and then we saw these folks just either leaving or getting disinterested, or I don't know what was happening in these institutions, but we saw an engagement initially, and then lack of attention to many of these projects, even in US. So I think that was very shocking to me that even in US, we have kind of regressed. And I'm not trying to be political. I just am speaking as a data scientist, that I see that the policies were not there to help us move forward in this journey. That really, really surprised me, and it shows you how critical that support is.
Yeah, absolutely. So going forward, I mean, Dr. Bedelia talked about the variants of COVID, and we know that there are more epidemics on the horizon. What can you say for the future? What do you have? Do you have some predictions for the future? Do you have some advice for policymakers now that we have a new government that we can use to contain this epidemic and eliminate it altogether?
When you look back, I think Bill Gates predicted this big pandemic, and people even blamed, there was this myth and misinformation that the Gates Foundation is behind releasing COVID-19 virus. Obviously, that's so wrong, but we did hear that. So I think now maybe it was hard for Bill Gates to do that 2 years, 3 years before COVID-19, but it's obvious with that we live in a very global environment now. There's so much travel. I traveled 4 times in the last 12 months to Pakistan, although we were amid lockdown. I have business there. I have to go back to meet with the team to make sure, our models are working fine. So I think, you know, it's a very global world, and I won't be surprised if we see more of these pandemics rather than less. It's rather obvious there. So I don't see this threat going away. I think we need to become more aware of these pandemics. We need to really prepare for these, and we didn't see that. We didn't see that preparation. We didn't see everybody coming together, the public health authorities, the CDC, the government. So I hope the Biden government here brings them all together, and then we can launch a strong response, because I think we'll need that going forward.
And a unified response, I think,
Yes.
because we aren't really unified at the local, state, national, international level. And like both of you have said, we're such an interconnected world that certainly what happens in Texas is going to affect us in Boston, or what happens in the UK. It's impossible to avoid that. Any points you'd like to summarize for us before we'll be moving on to Amar Kumar, who is Chief Product Officer at Pearson. But I would love to hear any concluding thoughts before we end this session.
Thank you, Breen. I do want to say one thing to budding entrepreneurs out there, that there's a lot of opportunity. There's a lot of work that needs to be done in AI, in these models. And as I said, the workflows are critical. Providers are unhappy with current workflows. Our models need a lot of work. This is a very big opportunity for companies like ourselves to come forward. We were surprised to get so much attention with our model, which was just helping our own providers, and we really didn't do that to get any attention. We were just doing our work, and we were surprised how valuable it was. So I think the thing I want to emphasize is there's a lot of opportunity there. And I would encourage everybody who wants to be an entrepreneur to take that opportunity and go forward with their solutions.
Thank you so much. I learned so much just by talking to you today. I'm sure everyone, all the attendees, have also learned from you. So I really appreciate your taking the time, to share your personal journey, information about artificial intelligence as a response to COVID, and treating COVID and detecting COVID, and also talking to us about Persevia. And I could keep on asking questions, but I want to also bring back Fariha, who is going to introduce our next speaker. So Fariha, with that, I think I will hand this over to you.
Thank you.
Sorry, I think we'll give the audience a little bit of a break, and then we'll come back to our final, but not least important session. Very, very excited to hear a little bit about how the pandemic has changed and actually just accelerated innovation in the EdTech space. So folks, hang on, go ahead, grab a coffee, take a quick break, and we will be back around 12 o'clock. Thanks.